I'm Michael Battelle, the president and founder of the Fatty Liver Alliance, and I'm here today with three esteemed liver specialists. Dr. Naim Alkhouri is the VP of Academic Affairs, the Chief of Transplant Hepatology, and the Director of the Fatty Liver Program at Arizona Liver Health in Phoenix, Arizona. Dr. Mark Swain is the Director of the University of Calgary's Gastroenterology and Hepatology Division and a member of CANASH, that's the Canadian NASH Network Steering Committee. Dr. Tracey Simon is a hepatologist in the Division of Gastroenterology and an instructor of medicine at Harvard Medical School. Her research focuses on developing strategies to prevent cirrhosis and reduce the risk for hepatocellular carcinoma. We're here today to discuss a very important paper that Dr. Simon co-authored, and the study was published in Gut in July 2021, which included 10,568 participants. Mortality in biopsy-confirmed non-alcoholic fatty liver disease results from a nationwide cohort. Dr. Simon, could you please tell us about the study and the findings?
Sure. Thank you so much, Michael. So we decided to do this study because there's a growing epidemic of NAFLD, both in the US and worldwide, and there are not enough studies yet that have included large enough populations to have a meaningful assessment of the actual absolute risks of adverse events in this growing population. And so it has long been held that progressive NAFLD, especially NAFLD with fibrosis, is associated with excess mortality, and the leading sort of expectation is that this is cardiovascular related death. However, all of this information is based on relatively small studies or studies with NAFLD that has been defined in a variety of ways using surrogate measures. So what we tried to do in this study was to define the largest population we could find of patients with biopsy-confirmed NAFLD. So we took all patients in Sweden and collected the liver histology from 1967 to 2016. And we used a validated approach to define NAFLD from those biopsy reports. And then we looked ahead to see what was the absolute risk of mortality and what were the causes of mortality, both overall and according to the severity, the histological severity of NAFLD. And I will share what we found. This is our main figure from the study. And what you see on the left is the cumulative incidence of all-cause mortality in patients with NAFLD compared to matched controls. So like, as Michael said, there were over 10,000 patients with biopsy-confirmed NAFLD who were matched by age, sex, calendar year, and county of residence within Sweden to population controls. And so what's shown in blue are the mortality rates in patients with NAFLD, and in red, those are the matched comparators. And as you can see, there was a significant difference, and patients with NAFLD had significantly higher mortality rates compared to controls. That is something that is relatively well established from a variety of studies, but it helped us feel good about the validity of our cohort to see it represented here as well. What was a little bit more novel and felt more important to us were the findings on the right-hand portion of this figure, where we had enough of a population, enough of a size that we were able to distinguish mortality rates according to the histological severity of NAFLD. And what we saw is that with worsening disease severity, mortality rates increased progressively, but this wasn't just limited to patients with advanced fibrosis, which I think is one of the key takeaways of our study. And so patients with simple steatosis are shown in green, or in that yellow-green color, and then NASH without fibrosis is shown in the more green color, and then blue is patients with non-cirrhotic fibrosis, and then cirrhosis is in purple. And even when we specifically compared patients with simple steatosis to healthy controls, we saw an absolute excess risk of overall mortality. When we compared patients with NASH to simple steatosis, we saw a further increase in overall mortality, and so forth as the histological severity of NAFLD progressed. The other primary finding from our study was that we looked at cause-specific mortality as well, and we found that the highest contributor to the excess mortality risk in this population was not cardiovascular disease, but rather extrahepatic cancers. An important caveat is that these are absolute rates of overall mortality, and there was still an excess absolute risk of cardiovascular death, but it was much more modest than we had anticipated.
That's great.
So I will open it up to the group for comment and concern.
Mark?
Yeah, well, first of all, I'd like to say that's an amazing study. I think it was actually quite a nice paper to read. First of all, congratulations. It was a huge number of patients, a lot of work, and the analyses are really phenomenal, actually, really amazing. And I think certainly it's discussion provoking in many ways. I guess my only thing I'd be very interested in your thoughts on this. I know you kind of addressed a bit in the paper, is I guess the two things that sort of jumped out at me, well, I think is the one that would jump out at anyone, is that the alcohol history, of course, is always concerning, especially in a Scandinavian country. And I recognize that through the history of drinking in Sweden, it changed over time, and it's changed a number of times, but it is in the Scandinavian belt of alcohol consumption, and one would expect that to be an issue, even though it wasn't coded in an administrative codes that require either admission or a discharge or a specialist referral. Often people don't record that because it's not family practice based. So that's number one. I'd be interested in your thoughts on that. I know you have a validated code and you looked at liver sort of coding, but not, it wouldn't pick up those other ones essentially necessarily. And then the other thing is the obesity rate. It's almost like this is a lean NASH study. If you say these are all NASH and they're not alcohol, then a 4% overall obesity rate is like so far off of what we expect. I know you kind of say, well, this is what people see, and then in your control population, it's 0.4%. So there's a 10-fold difference in obesity rates. And I'm just wondering, can you start to say, well, actually, the controls are actually super fit. And so you've got this super fit control group against a group that you're actually looking at an obesity effect. Even though obesity is so low, it's still 10-fold higher.
Those are two really important points and big limitations of this study. So so in terms of alcohol, we feel slightly better about the alcohol question than about the obesity. So I'll start there. And the alcohol abuse is absolutely, it's undercoded in these administrative data sets. So what we don't know what we don't know. And that could be a confounder both in the NAFLD cohort and also amongst the controls. And we tried to use surrogate measures of alcohol abuse, and we also, when we validated the histology cohort itself, we validated against the reports and then used medical charts when we were able to in a very small subset. And we didn't find evidence of alcohol either in the codes, in the report from the pathologist, or in the clinical indications provided by the ordering physician. That being said, as you know, in clinical practice, that is not always where those things are going to be recorded, and so it absolutely could have been missed. And
can I just ask one question that's sort of linked to that? So in the reports that you would get from that are put into this espresso, is that it? Yeah. Do they put like, is there a history? Is there an indication for the liver? But I'm just curious, I mean, do they say fatty liver or abnormal liver tests? I mean, what was the main indication that drove these biopsies to be done?
Abnormal liver function tests or fatty liver disease were the two largest in the validation study that we did in that subset. And there were, in some of the cases that were excluded for alcohol use, alcohol was mentioned either in the report from the pathologist who was referencing the indication or in the indication itself. But the problem we always face in these administrative data sets is that we probably have a very poor negative predictive value for these conditions. And so we have a lot of faith in our positive predictive value and not so much in the places where it's not mentioned. We did feel confident about the diagnosis of NAFLD and the exclusions that we used. And so for that reason, that's why we spent so much time in our subgroups looking at the NAFLD only cohort and taking out the population controls, because at least everyone had a biopsy that we were able to sort of use our validated subgroup and in order to repeat the analyses and demonstrate similar results, but that's certainly a limitation. In terms of obesity, the issue is larger, and I think that the answer probably is not that this is a super fit population, rather that obesity is very, very undercoded. When people visit doctors, they're probably not billing for obesity nearly as much as there actually is obesity. There have been studies by some of my collaborators in Sweden that have demonstrated that the rates of obesity in patients with NAFLD and NASH are commensurate with what we see here in the US and in other parts of Europe. Sweden in general is a leaner society than the US for sure, but
well, it's trying to do very hard to catch up.
It is trying to catch up.
Like Canada.
But my guess is that it's confounding related to missing data more than being a very, very, very healthy population.
So just last question. I'm just wondering if you took, so you in your control population, even though there was 4 to 5 to say 5 to 1, sort of that where you controls to people in your cohort. If you took people that were actually that fit an obesity diagnosis but not a NAFLD diagnosis in that cohort, because NAFLD, of course, they haven't had a biopsy, but any other thing that might indicate NAFLD, because you do have their other administrative health records and ultrasounds or whatever, you could even do other score. It'd be interesting to know if that still holds, that once you compare to that type of group.
Yes, I think so too. It's especially for the excess rates of mortality seen in the simple steatosis group.
Exactly, yes.
We wondered if in particular that difference was related to obesity. We didn't do that analysis specifically. We did do we did try to propensity match at one point according to all of those factors, but in truth we didn't end up using those results. The results were similar. But it's difficult because we worry that obesity is just so underreported that somehow that might be a very different subset of people if we take everyone with a recorded code of obesity as the controls, that we didn't know sort of what new bias we might be introducing by doing so.
Sure.
But it's very, your point is well taken. It's a problem. We didn't really know how to surmount that issue.
Thanks, Mark, for those great questions. Naim, what burning thoughts do you have?
Yeah, no, great discussion and congratulations again. I mean, this is, I call this a landmark paper because it really shows the impact of the entire spectrum of NAFLD. I think we have a dilemma in our field with this NAFLD spectrum that, initial studies by Art McCullough in Cleveland showed that NASH, where you have ballooning inflammation, these are the patients that progress to cirrhosis and liver outcomes. And then Paul Angulo in 2015 published a paper in Gastroenterology trying to dispute the concept of NASH, saying that fibrosis is what mattered. And then we had, several papers confirming this. I think what Paul was trying to say is that, we got in a position where you have patients with F3 fibrosis, bridging fibrosis, but no activity, no ballooning, not much inflammation. And we say they don't have NASH. Well, what does that mean? I mean, these are patients that progress to F3. So he wanted to make the point that fibrosis by itself is very important. He didn't intend to make the point that, NASH didn't matter, that steatosis didn't matter, but this is the interpretation that we went with in the field. And now if you look at, pharma companies, FDA endpoints for clinical trials, everything is focusing on having NASH with F2, F3 fibrosis to get a drug, into a trial. And I think this is really a missed opportunity. I think the most important finding from Tracey's study in my mind, and tell me if you agree or disagree, but the excess mortality related to cirrhosis and HCC in patients with simple steatosis. I mean, the way I looked at the data, there was a 9-fold increase in dying from cirrhosis, 7-fold increase in dying from HCC in simple steatosis compared to the control group. This is significant. And I think, what we need to understand that fatty liver is just not good for you, okay? I mean, we hear this discussion all the time that it's a, imaging finding. finding. It doesn't matter. Until you have F3 fibrosis, you're not going to die from liver disease. And I think this study shows clearly that, one biopsy in your lifetime is not going to tell you everything you need to know about your liver. You may have simple steatosis today, but you can progress to NASH and even fibrosis, cirrhosis later in life. And this is a very important point, for us to make. I think, of course, we have to think about cost effectiveness. I think we don't want to use medications to treat this, but I think screening for NAFLD, implementing an intensive lifestyle intervention early on is very paramount. And I think, this study highlights why we need to do this. And, once you lose weight, you improve your insulin sensitivity, your NAFLD is going to get better, but also your lifespan is going to increase, and you're less likely to die from cirrhosis and liver cancer and extrahepatic cancer. So, I think this is a very important study that we need to highlight and discuss more in the NAFLD field, because we need to intervene early and not wait until people have NASH with F2, F3 fibrosis. What's your take, Tracey, on the simple steatosis group?
I couldn't agree more. I think that we all too often in the fields are reassuring to our patients if they do have a biopsy or they do have a non-invasive score that suggests that they are very low risk for having significant fibrosis. And sometimes those patients aren't encouraged to follow up that frequently, or we lose track of them. And we don't focus on intensive lifestyle modifications to prevent adverse events down the road. And the data very, very clearly supported that even early stage disease is associated with scary adverse events and very high rates of adverse events, both liver related and as sort of extra hepatic. And that is, I think it should be a wake-up call for us to do more early on for our patients, be that at the primary care level and when they arrive to our clinics in hepatology, and to be more aggressive early on to try and prevent these complications, without a doubt.
And Michael, just so you know, it's not that common that you read a paper that changes the way you practice, but this was one of these papers because, I'm guilty. We do FibroScans on every patient that walks through our clinic. And when you see a very high CAP score indicating severe steatosis, but very low stiffness, indicating, no significant fibrosis, I was very reassuring to my patients. I'll say, hey, let's focus, on your cardiovascular risk, but don't worry too much about the liver. Your liver is going to be okay. But this study shows clearly that probably it's not the case, and that we need to counsel these patients differently, especially when they're younger. If you're 75-year-old and you have no liver stiffness, no fibrosis, maybe you're okay. But if you're 25, this is a big deal, and we need to change the way we counsel. And we should not discharge these patients from our hepatology clinics. Probably we should follow them. It doesn't have to be every 6 months. It could be every 2-3 years. But I think, doing that liver assessment periodically is very important.
You're going to have to train a lot of hepatologists. That's 25-30% of the population, man.
Well, I think we need to primary care physicians have to take care of that. This is like type 2 diabetes. You don't need an endocrinologist. We need to really train primary care physicians to understand the impact of this.
Naim,
sorry, go ahead.
I was going to just comment quickly on what Naim said too, that something that we can take away from this that is actionable is and it was a recommendation in the paper, is to help patients reverse NAFLD. So prevention for sure is important, but reversing it is something we can actually act on to give them the tools that they need and the education they need to help themselves if it's possible.
I was gonna raise one point too that I think is so, and Tracey touched on it, is that these patients, the main indication was an abnormal liver test. But if you look at certainly in our population-based case finding study in the recent publication by Steve Harrison in JHEP, where they looked at when you start to go into populations, more population, and I understand this is a population-based biopsy study, but they were being biopsied for a reason. But if you look at when you start to delve in and look at the number of people that actually, the percentage of the population has abnormal liver tests, but still has significant disease, whether it's by non-invasive or invasive approaches, it's about half. So you're looking at half the people that have normal within the properly defined normal ranges. And so we're missing, there's a lot of people here that are potentially at risk that are not even really probably coming to care because their liver tests are persistently normal, which makes it even more concerning.